Okay, so we will start our class. Today's session. I'll share my screen and then I'll start today's session. Give me a moment. Yeah, one second. One second. So, yeah. So, good evening, everyone. Today is the fourth live session of the series of sessions that we take for the course Host Pathogen Interaction, Immunology. So, basically, what we do. So this course is taken by course instructor Professor Himanshu Kumar from IISER Bhopal. So in these live sessions, what we do is that basically we go through some of the old previous year assignment questions and we discuss the answers to those questions. Not only the answers to those questions, but we also discuss the basic concept behind those questions. We sometimes also go to the advanced concepts, so that it's easier for us to solve similar type of other questions as well, right? So that is exactly what we do for these in these sessions. So this is week 4. I'll start the session for today. So the first question for today is, what is the primary purpose of the Gruber-Widal test? Option A, to detect antibodies against Salmonella typhi in the patient's serum to diagnose typhoid fever. Option B, to identify bacterial toxins in the blood for rapid typhoid diagnosis. Option C, to observe bacterial growth patterns in blood samples. Option D, to differentiate between typhoid and other bacterial infections using heat-stable antibodies. Option E, to detect complement activation leading to bacterial lysis in typhoid patients. So these are the five options. I'll wait for a few minutes. If you know the answer, you can just let me know, or you can just type in the chat box as well. I'll wait for a few minutes, then I will start discussing the question. Anybody? Okay, so the correct answer will be option A, which is to detect antibodies against Salmonella typhi in the patient's serum to diagnose typhoid fever, right? So, a little bit why the Gruber vital test? It's basically a serological agglutination test that detects anti O somatic and anti-H flagellar antibodies against Salmonella typhi and even sometimes Salmonella paratyphi in a patient's serum. So a significant rise in antibody titer supports the diagnosis of the typhoid fever, right? So the option B is incorrect because it does not detect bacterial toxins. Option C is incorrect because it is not a culture or growth based test. Option D is incorrect because it does not primarily differentiate typhoid from other infections using heat stable antibodies as a defining principle. And option E is also not correct because it does not assess complement activation or bacterial lysis, right? So, as I said, basically when serum from a patient infected with salmonella is mixed with standardized killed salmonella antigens, visible agglutination occurs if specific antibodies are present. So basically what happens is that the test mainly detects antibodies against O antigens, that is the somatic antigen. Heat stable that appears early in infection indicates active or recent this infection, right? And H antigen, which is the flagellar antigen, it is heat labile, appears later, indicates past exposure or immunization, right? Past exposure or immunization. So some kits can also include AH and BH antigens. For S paratyphi, that is S paratyphi A and B, right? So now if you talk about the procedure is like it sounds simple, but I'm pretty sure it's exactly from a clinical point of view, it's really complicated. So basically, patient sample is collected, like patient serum is collected, and serial dilutions of that serum are prepared. Now, known salmonella O and H antigens are added, right? Now, agglutination is observed visually, and the highest dilution showing agglutination is the antibody titer, right? So, yeah. So interpretation is like a fourfold rise in the titer between acute and convalescent sera is diagnostically significant, and single high titers must be interpreted cautiously due to prior vaccination, endemic exposure, cross reactivity, and all of that. Now, what's the clinical use? Used mainly in resource limited settings, helpful after the first week of illness, and although not the gold standard, blood culture is preferred in early diseases, right? So we'll talk about, as I said, there's an infectious feverish disease caused by the bacterium Salmonella typhi, Salmonella enterica cerebrotiphi, and less commonly by Salmonella paratyphi. So it is an acute generalized infection of the reticuloendothelial system, intestinal lymphoid tissue, and the gallbladder. Now the infection always comes from another human, either an ill person or a healthy carrier of the bacterium. So the bacterium is passed on with water and foods and can withstand both drying and refrigeration. Now, what are the causes? As I said, it's caused by the bacterium Salmonella typhi. The ingestion of contaminated food or water, then contact with an acute case of typhoid fever, then water is contaminated where inadequate sewerage systems and poor sanitation, eating food or drinking beverages that handled by a person carrying the bacteria. Salmonella enteritidis and Salmonella typhimurium are other Salmonella bacteria causing food poisoning and diarrhea. Now talking about Salmonella enterica, member of the genus Salmonella, it's rod-shaped flagellated aerobic gram-negative bacterium. Large number of fimbrial and non-fimbrial adhesins are present, mediate biofilm formation and contact to host cells. Now secreted proteins involved in host cell invasion and intracellular proliferation. It can infect cattle, poultry, domestic cats, hamsters, humans, etc. Now, pasteurizing and food irradiation can kill salmonella for commercially produced foodstuffs containing raw eggs such as ice cream. Now, foods prepared in the home from raw eggs can spread salmonella if not properly cooked before consumption. So the organisms causing enteric fever possesses two major antigens, namely the somatic antigen O and a flagellar antigen H, along with another surface antigen VI, right? So during infection with typhoid or paratyphoid bacilli, antibodies against flagellar antigen of S. typhi, which is SH, S. paratyphi, which is AH, and S. paratyphi B, BH, and somatic antigen of S. typhi O usually become detectable in blood 6 days after the onset of infection. So, ingestion of contaminated food or water, that is Salmonella bacteria. It can invade small intestine and enter the bloodstream. It is carried by white blood cells in the liver, spleen and bone marrow, multiply and re-enter the bloodstream. Now, bacteria invade the gallbladder, biliary system and the lymphatic tissue of the bowel and multiply in high numbers. And then they pass into the intestinal tract and can be identified for diagnosis in cultures from the stool tested in the lab. Symptoms is there basically no symptoms. If only a mild exposure, some people become carriers of typhoid, poor appetite, headaches, generalized aches and pains, fever, lethargy. Lethargy is basically a state of tiredness, weariness, fatigue, or lack of energy. It can be accompanied by depression, decreased motivation, or apathy. Diarrhea, have a sustained fever as high as 103 to 104 degrees Fahrenheit. Chest congestion develops in many patients and abdominal pain and discomfort are common. Constipation, mild vomiting, slow heartbeat, all of that. Now time frame, it basically occurs gradually over a few weeks after exposure to the bacteria. Sometimes children suddenly become sick. The condition may last for weeks or even a month or longer without treatment. Now, what is the first stage typhoid fever? So, the beginning stage is characterized by high fever, fatigue, weakness, headache, sore throat, diarrhea, constipation, stomach pain, and a skin rash on the chest and abdominal area. So, according to the Mayo Clinic, adults are most likely to experience constipation while children usually experience diarrhea. So what is the second stage? Second stage will be basically characterized by weight loss, high fever, severe diarrhea and severe constipation. Also the abdominal region may appear severely distended. Then the typhoid stage. So when typhoid fever continues untreated for more than 2 or 3 weeks, the affected individual may be unable to stand and move and the eyes may be partially open during this time. So at this point, fatal complications may emerge. Now about the diagnosis. Diagnosis of typhoid fever is made by blood, bone marrow or stool cultures test or a Weedle test. So what are the prevention? Two main typhoid fever prevention strategies. Either vaccination. The first type of vaccine contains killed Salmonella typhi bacteria administered by a shot. Second type of vaccine contains a live but weakened strain of the Salmonella bacteria that causes typhoid fever. It's taken by mouth. And the medication are antibiotics, like antibiotics such as ampicillin, chloramphenicol, amoxicillin, etc., used to treat typhoid fever. If we talk about the serology, so it's basically the study of blood serum with emphasis on testing of antibodies in the serum. So, a substance which stimulates the body to produce antibody, usually a foreign substance. Antibody is like protein molecule produced by the body's immune system in response to specific antigen, right? And the antibody combines with the antigen and disables. So it's also called immunoglobulins, IgG, IgM, IgA, IgE. It is also referred to as anti. It is the name of the antigen. Example, anti-HCV and anti-HAV. Now, when we talk about the Widal test, it's basically a test involving agglutination of typhoid bacilli when they are mixed with serum containing typhoid antibodies from an individual having typhoid fever used to detect the presence of Salmonella typhi or Salmonella paratyphi. So as I said, basically these are how the experiments are done. All the reagents are first thawed to room temperature and test sample, which is the sample taken from the patient, is taken, and positive control is marked as PC, negative control will be marked as NC, and all the antigen solutions are added to it in various dilutions and ratios, as I said, and then these are mixed thoroughly with the help of an applicator, right, and rotator, and then basically agglutination is checked for. Like if the antibodies, particular antibodies, are known to be present in the sample, some kind of agglutination is checked for at the end of it. It's an end point study. So if you talk about the antigen antibody reaction, the principles and applications, very important section of the immunology course. So basically the antibody antigen reaction is a biomolecular association similar to the enzyme substrate interaction but with few differences, because it does not lead to irreversible chemical alteration in either the antigen or the antibody. It is a non-covalent interaction which includes hydrogen bond, ionic bond, hydrophobic bond, and van der Waals interaction. Now, strong antigen-antibody interaction depend on a very close fit between the antigen and the antibody. Now, what are the types of diagnostic tests? Many types of diagnostic tests are performed in the immunology lab. Most of these tests can be designed to determine the presence of either the antigen or the antibody. So, major uses of the serological tests are when the diagnosis of infectious diseases, like when the organism cannot be cultured, as in syphilis, hepatitis A, B, and C, when the organism is too dangerous to culture, like rickettsial disease, when culture techniques are not readily available, that is HIV, when the organism takes long time to grow, like hypoplasma, and diagnosis of autoimmune disease like antibody against DNA in SLE, determination of blood type and HLA. So, basically precipitation reaction, agglutination reaction, then we have chromatography, immunoassay, and antibodies are labeled antigens. So for precipitation reaction is PPT, precipitates in soluble or gel, single radial diffusion, double diffusion, precipitate in agar with electric field, immunoelectrophoresis, all of that, counter immunoelectrophoresis, all of these are there. For agglutination, we have direct blood group or bacterial agglutination. Okay, this is how samples are taken. So a sample from a venous blood from the patient and clot is taken and the clot is allowed to form. Now the clotted sample is centrifuged to collect the serum, clear serum. Now antibody and soluble antigen interacting in aqueous solution form a lattice that eventually develops into visible precipitate. So the antibodies that aggregate soluble antigen are called precipitants. So precipitate depends on antibody must be bivalent and precipitate will not develop with monovalent FAB fragment. Antigen must be either bivalent or polyvalent and all of that. So what are the types of precipitate test? Is basically in solution, which is the reaction can be made quantitative. In agar of many times, which are single diffusion, radial immunodiffusion, Mancini method. In it, antibody is incorporated into agar and antigen is measured into a well. As the antigen diffuses with time, precipitation rings form depending on the antigen concentration. Such radial immunodiffusion is used to measure IgG, IgM and complement component and other substances in the serum, but not IgE because its concentration is too low. Then for double diffusion or which is also known as the Octoloni method, in it the antibody and the antigen are placed in different wells in agar and allowed to diffuse and form concentration gradients, right? With line of precipitate formation. So this method indicates whether antigens are identical, related, but not identical or not related. So it's a qualitative view. Then we have the precipitate in agar with electric fields, which are basically immunoelectrophoresis, of which the serum is placed in a well in agar or a glass slide, then current is passed through the agar, and a protein move in the electric field according to their charge and size. Then a trough is cut into the agar and filled by antibody. As they move towards each other, they form a series of arcs of precipitate used in diagnosis of human myeloma protein. Then we have counter immunoelectrophoresis. It relies on movement of antigen towards the cathode and antibody towards the anode with meeting visible in 30 to 60 minutes. Used in detection of bacterial and fungal antigen in cerebrospinal fluid, right? Then we have rocket electrophoresis. Basically, it's a quantitative technique of which it permits measurement of antigen levels. In it, the negatively charged antigen is electrophoresed in a gel containing antibody. The precipitate forms the shape of rocket, the height of which is proportional to the concentration of the antigen. Then we have rocket immunoelectrophoresis, which is antigen is electrophoresed into gel containing antibody. The distance from the starting well to the front of the rocket shaped arc is related to antigen concentration. Okay. Give me a minute. So it's an interaction between antibody and particularly antigen resulting in visible clumping or agglutination. So the antibody that produces such a reaction is called agglutinin, and this reaction needs a polyvalent antigen. So as an excess of antibody inhibits precipitate reaction, it will also inhibit agglutination, and this is called Poisson effect. So what are the causes of the Poisson effect? High antibody concentration. This will result in univalent binding of the antibody to antigen. So no cross-linking of one antigen to another. To overcome this, you must dilute the serum. Incomplete antibody, like often of IgG, this antibody may occupy most of the agic site. This block the excess by IgM, which is a good agglutinin. I'll not go into the process. So as I said, coming back to the viral test, the test depends on the ability of antibody in the patient's serum to agglutinate the stained bacterial antigens. So when this occurs, the aggregates become clearly visible to the naked eye. So suspension of bacterial stain and kill and all of that. I'm not going to do much detail. A little bit background on Salmonella also. It's a genus of rod-shaped gram-negative non-spore forming predominantly motile enterobacteria with diameters around 0.7 to 1.5 micron, lengths from 2 to 5 micron, and flagella which grade in all directions. Now, Salmonella is closely related to the Escherichia genus and are found worldwide in cold and warm-blooded animals, including humans, and in the environment. They cause illnesses like typhoid fever, paratyphoid fever, and foodborne illness. Now, they are often pathogenic for humans or animals when acquired by the oral route. They are transmitted from animals and animal products to humans, where they cause enteritis, systemic infection, and indirect fever. Salmonella typhi causes typhoid fever. S. choleraesis causes bacteremia. We talked about all this. So coming back to the question that we started with, what is the primary purpose of the Gruber viral test? The option is A. To detect antibodies against Salmonella typhi in the patient's serum to diagnose typhoid fever. Okay? If anybody has any doubt in these questions, you can let me know. Anybody? Anybody has any questions? If not, then we'll move on to the next question for today. Okay, so I'll move on to the next question for today. What is the key observation in the Pfeiffer phenomenon? Okay, the options are A. Vibrios undergo phagocytosis in immune animals. B. Vibrios are killed by immune cells in the peritoneal cavity. C. Vibrios undergo bacteriolysis in immune animals, swelling, dissolving, and disappearing within 20 minutes. D. Immune serum prevents vibrios from multiplying in test tubes. E. Vibrios are engulfed and destroyed by cellular activity in immune animals. In detail. So, I'll wait for a few minutes if anybody wants to try.
Ma'am, can you please explain these slides slower, ma'am?
Sorry, can you repeat?
Can you please explain slowly,
Sure,
ma'am, the concepts?
sure, I'll go slow. Sure. Sure.
Thanks.
Yes, I'll go slow. So anybody wants to. Anybody would like to answer? Okay, so we'll talk about the Pfeiffer phenomenon, right? So The Pfeiffer phenomenon is a classical immunology observation demonstrating antibody-mediated complement-dependent bacterial lysis in vivo. Right? So it was described by this scientist Richard Pfeiffer while studying Vibrio cholerae. Right? So the correct option will be So the correct option will be option C, which is Vibrios undergo bacteriolysis or bacterial lysis in immune animals, swelling, dissolving and disappearing within 20 minutes. Right? So the core concept of this is that when cholera vibrios are injected into the peritoneal cavity of an immunized animal, the bacteria can swell, lose motility, undergo lysis and even disappear within 20 minutes. So this lysis occurs extracellularly, not by the method of phagocytosis. And what is the mechanism behind the phenomenon? So specific antibodies like anti-vibrio antibodies are present in the immune animal. So these antibodies bind to the bacteria. Now the complement system present in vivo is activated and the membrane attack complex forms. Now the bacterial cell membrane ruptures, undergoes lysis, and this proves the role of humoral immunity, that is antibody plus complement in bacterial killing. Right? So a little bit of history. So Buckner was the first to observe that bactericidal effect of serum was destroyed by heating at 55 degrees Celsius for 1 hour. The Pfeiffer's phenomenon came in 1894. We'll talk about that. So what is the complements system? So if you have heard about the complement system in immunology, it's basically the system of factors activated by the antigen-antibody interaction that mediates a number of biologically significant consequences. Okay. So a heat labile protein that is present in the cell of human beings and animals. Okay. So if you want more detail about the complement system, so it constitutes about 5% of the normal serum proteins. It combines only with antibody antigen complex. Okay. So all of that. So if you want a detailed but simple explanation of complement system of immunology, so basically the complement system, give me a minute. One second. So basically the complement system is a group of around 30 or I guess a little more than 30 plasma proteins, mainly C1 to C9 basically. So in blood in inactive form. So when we talk about inactive form, it's basically zymogen form. Okay. So they are called complement because they complement the action of antibodies in immune defense. We know about antibodies that B cells produce. We have talked about this in the previous classes, right? So basically this role of this system is to complement the activity of these antibodies in, in defending the organism against pathogens. So what are the core functions of complement? Bacterial lysis, opsonization, inflammation, immune complex clearance. Okay. So in the Pfeiffer phenomenon, the bacterial lysis function is the key, right? So complement components can be produced by the hepatocytes, also by blood monocytes, tissue macrophages, and the epithelial cells of gastrointestinal and genitourinary tract. Okay, they constitute about 15% by weight of the serum globulin. They can circulate in blood in inactive form like proenzymes, and the cleavage of proenzymes exposes active site by removal of an inhibitory fragment. So the products of one step, that is the activated enzyme, act as catalysts for next step. This sequence is called complement cascade. Okay, so it basically can be of two, these are the pathways of the complement activation: the classical pathway and the alternative pathway. So in the classical pathway, it is basically triggered by the antigen antibody complexes. IgG or IgM antibodies bind to bacterial surface antigens. Now the C1 complex, C1q, C1r, C1s, they bind to the Fc region of the antibodies. It basically starts the activation cascade like C4 to C4b, C2 to C2a, and then that gives rise to the formation of C3 convertase and the massive cleavage of C3 like C3a and C3b. Whereas in case of alternative pathway, it's basically antibody independent, right? It's triggered directly by bacterial surfaces like lipopolysaccharides, endotoxins, etc. Then there is also something called the lectin pathway, which is activated by mannose binding lectin or MBL. It is antibody independent. Now, what is the terminal complement pathway that is common to all? Like C3b binds, it can form C5 convertase. C5 will get ruptured into C5a and C5b. C5b will further recruit C6, C7, C8, and multiple C9 molecules polymerize and formation of membrane attack complex. Okay, and these membrane attack complex will create pores in the bacterial membranes, which leads to osmotic lysis. Now, why Vibrios lies in the Pfeiffer phenomenon? I'll come to this. Yes, these are the components of the complement system. Basically, whatever I explained, you have the bacterial cell membrane with antigens, IgG recognizing and all. So C6, C7, C8 and C9, they will assemble to form the membrane attack complex, right? The MAC. That will form a pore, and this membrane attack complex will create pores in the bacterial membrane, leading to osmotic lysis. As I said, the classical pathway is initiated by binding of antibody to antigen. It's predominantly IgM and certain IgG subclasses. Soluble antibody antigen complexes, free floating, all of these, and antibody complex to antigen still adhered as surface antigen. Okay, so you don't need to worry. I will upload all of these slides and I will also upload the videos of these classes. These are being recorded, so these will be uploaded. Okay, so don't worry about losing any information. Now, complexing of antibody with antigen is basically induces conformational changes in Fc portion of antibody, exposes binding site for C1 fragment complex. Okay, So basically C1 factor binds to single IgM that is bound to antigen. Now for activation, C1 must bind more than one Fc. C1 bound to Fc activates C4, C1 and C4 activates C2. And C4B2A C3 convertase C3 proenzyme active enzyme forms C3 anaphylactoxin, generates greater than 200 molecules of C3b, that is the amplification step. Now the role of C3b is opsonization, viral neutralization, clearance of immune complexes, cascade continuum, like it binds C4B2A. Then we get the C5 convertase, which is a trimolecular complex. The cleavage of C5 coenzyme to active form, as I said, C5A and C5B, right? And C5B will recruit C6, C7, C8, which will initiate the MSC or the membrane attack complex, which further consists of C5B, C6, C7, C8 and C9. And this will form pore in the membranes leading to cell death. Okay. Will not go into too much. I talked about the lectin MBL pathway, right? Microbial carbohydrates. So the lectin pathway gets activated by the mannose binding lectin MBL. Okay, this one, and it's also independent of the antibody. So the biological effects of complement, basically if we try to list down, they are basically immunological membrane damage like cytolysis, bacteriolysis, pathogenesis of certain hypersensitivity reactions, antiviral activity, and promotes phagocytosis and immune adherence. Okay. So these complement proteins are responsible for these functions. Like cell lysis, we have C5b9 mast cell basophil degranulation, we have C3a, C4a, C5a, antigen opsonization, C3b, C4b, all of these. Okay. So deficiencies of the complement system. So the classical pathway, which is the C1, C4 and C2 for immune complex diseases like discoid or systemic lupus, erythematosus, all of these. Pneumococcal infections. Then we have MBL pathway, which I said the lectin dependent pathway. They are known for recurrent infections, accelerated course of SLE and rheumatoid arthritis again. Then we have alternative pathway. Like severe fumigenic, fulminant pyogenic nasal infections with a high mortality rate. Then we have C3 factor H and factor I, right? Then we have predisposed to pyogenic bacterial infections, and the terminal pathway, which is C5 to C9, which is nasal and bacterial infections. Give me a minute. So, when we talk about the Pfeiffer phenomenon, so what happens? Vibrio cholerae is a gram-negative bacterium, right? So, gram-negative bacteria are highly susceptible to MSC or the membrane attack complex. Again, I'll go back to MSC. Yes. So basically MSC will cause swelling, loss of mortality and cell rupture and disappears within 20 minutes. So this is extracellular bacterial lysis. Okay. Now why complement works in vivo but not in vitro? So complement is heat labile, inactivated at 56 degrees Celsius for 30 minutes. In test tubes, if serum is heated, no lysis, but fresh serum lysis is possible. That's why Pfeiffer phenomenon is classically in vivo, right? So basically, in a one-line summary, the complement system is a heat labile cascade of plasma proteins that, when activated via antigen antibody complexes, forms the membrane attack complex C5 to C9, causing extracellular bacterial lysis as seen in the Pfeiffer phenomenon. Right? That is the main gist of the Pfeiffer phenomenon. So I also said that the complement antibodies are called complement because they basically complement antibodies by enhancing bacterial killing, promoting phagocytosis, causing inflammation, lysing cells directly. So antibodies alone often bind but cannot kill. So complement completes the job. Okay. So and the major functions of the complement system are bacterial lysis that we discussed. That is with the formation of membrane attack complex MSC. It is especially effective against gram-negative bacteria. Then we have opsonization. It is a complement coats microbes easier phagocytosis. Then we have inflammation, which basically means attracting immune cells, increasing vascular permeability. Then we have immune complex clearance, so removes antigen antibody complexes from circulation. Then we have complement activation pathways. There are three pathways all converging at C3 activation. So as I said, the first step will be the C1 activation. C1 is a component of C1Q, C1R and C1S. Is a complex basically. So C1Q will bind to the Fc region of antibody attached to the antigen, and IgM is better because one IgM molecule can activate C1. IgG needs two molecules close together. Then the C1 will cleave, then C4, C4A and C4B. C2 will also be cleaved into C2A and C2B. C4B and C2A will give rise to C3 convertase. Now it's the C3 activation step. C3 convertase will be cleaved into C3A and C3B, and this is the central and most important step. While for the alternative pathway, the other kind of pathway, basically what happens, there is a direct contact with the microbial surfaces like lipopolysaccharide, endotoxin, fungal cell walls, and no antibodies are required. So the key point is part of innate immunity, slower but continuous. Then we have the lectin or MBL pathway. The trigger is mannose binding. Lectin binds to sugars on microbes. MBL activates enzymes similar to C1. No antibody is required. So as I said, what is the terminal complement pathway that is common to all? So once C3B is found, all pathways converge. And step by step terminal pathway starts like C3B binds C3 convertase, from C5 convertase, C5 gives rise to C5A and C5B. C5B sequentially binds C6, C7, C8 and multiple C9 molecules polymerize. So it basically forms the membrane attack complex MAC. Membrane attack complex is nothing but a cylindrical pore-forming complex. It inserts into bacterial membranes, creates pores, causes an imbalanced water influx, cell swelling, and cell lysis. Especially effective against gram-negative bacteria. So, if you're linking back to the Pfeiffer phenomenon, where what happens basically is that immune animal has specific antibodies and active complement. The result is that the antibody binds Vibrio cholerae, classical pathway activated, MSC or membrane attack complex forms. Vibrios can swell, lose motility, lyse, and disappear in 20 minutes. So, there is an extracellular bacterial lysis, not phagocytosis. So why Pfeiffer phenomenon is not seen in vitro easily? Complement cascade needs fresh serum, physiological conditions. And in vitro complement may be inactivated, hence weaker or absent lysis. So that is all about this question. We started about the Pfeiffer phenomenon. So the correct answer will be Vibrios undergo bacteriolysis in immune animals, swelling, dissolving and disappearing within 20 minutes. Okay, so if anybody has any question they can ask and I'll wait for a few minutes. Then I'll move on to the next question for today. So I'll upload all the slides and you can also see the YouTube video recordings. You can also go through the slides and the video recordings. And then if you have any doubt, you can ask me in the next class as well or via mail, not a problem. and wait for a few minutes. If you have any questions, you can ask, or we'll move on to the next question for today. Okay, so we'll move on to the next question for today. What did Edward Jenner use to develop the first successful vaccination? Option A, smallpox virus. Option B, cowpox virus. Option C, rabies virus. Option D, influenza virus. And option E, polio virus. And wait for a few minutes. You cannot answer. You have to give me a detailed answer. Anybody? I would like to try. Okay, so I'll go to the answer. Basically, Edward Jenner is a story of first successful vaccination, right? So he developed the first successful vaccination, I think, in 1790s or something like that. So what he did was he observed that milkmaids who had previously been infected with cowpox did not develop smallpox. So Jenner inoculated material from cowpox lesions into a young boy named James Phipps, and when later exposed to smallpox, the boy did not develop the disease. So, why cowpox work? So, cowpox virus is closely related antigenically to the smallpox virus. So, infection with cowpox produced cross-protective immunity against smallpox. So, cowpox caused mild disease, making it safer than using smallpox itself, right? So why the other options are here are incorrect? So the correct option is cowpox virus, right? So why the other options here are incorrect? Is because smallpox virus, this was variolation used earlier and was risky, but not true vaccination. If you talk about the smallpox, then option C is rabies virus. Option C is option C is rabies virus. Basically, used later by Louis Pasteur, right? Then option D is influenza virus, which is a vaccine developed in the 20th century, right? Much later. Then we have the option E, which is the polio virus. Vaccines developed by I think Jonas Salk and Albert Sabin. Some people like that. So the correct option here will be cowpox virus. So we'll discuss about the story of the first vaccination, right? It should be fascinating. So this was Sir Edward Jenner. So acute infectious disease caused by the variola virus and clinically characterized by sudden onset of fever, backache, headache, vomiting, and sometimes convulsions, especially in children on the third day of fever. It's a typical rash-like appears which is centrifugal in distribution and passes through successive stage of macule, papule, vesicle, pustule and scab with subsequent scarring. Okay, so basically smallpox is caused by variola orthopox virus. It's a large DNA virus, can be major or minor. Okay, There are various types of various categories of these. So hosts are all age groups, occupation like medical, nursing, and all of that. Immunity will be lifelong after infection. Secondary subclinical cases were common. They do not transmit the infection, only boost the immunity. So, what can be the environmental factors that promote the infection? Basically low temperature, high humidity, virus survival increased. Seasons can be winter and spring, ventilation, overcrowding, spread, all of these. So, what are the modes of transmission? It can be direct implantation on nasal, oropharyngeal, mucous membrane, secretion from the rash, scab, indirect like airborne, formite-borne, close contact with patients or their clothing or bedding. Is this required for infection? The incubation period can be 10 to 17 days. Okay, rarely 7 to 17 days. So, what are the signs and symptoms? Fever, backache, malaise, headache, convulsions in children, delirium, abdominal colic in adults. So, a rash appears after 2 to 4 days and progresses to characteristic stages of papules, vesicles, pustules, and finally scabs. So, scabs fall off at the end of third or fourth week. Now, what are the characterizations of lesions? So, on face and extremities, on trunk, distal part of limbs, and proximal extensor surface convexities. So, over a period of many weeks, the skin gradually returns to its normal appearance, right? And scars which last for life may remain on the face, an indication of previous infection with smallpox. Now, what are the complications? Like pustules is secondary infection, ocular, like bones and joints, respiratory like pneumonia, bronchitis, pulmonary edema, all of these. Then the gastrointestinal tract system like diarrhea, acute dilation of stomach, infection of intestine, then orchitis, encephalitis from the central nervous system. Diagnosis can be clinical and lab, skin scab, oropharyngeal, mucous membrane, conjunctiva, urine, etc. Now, the eradication. huh. So, people who survived from smallpox did not get the disease again. They got lifelong immunity. So, variolation is basically to infect healthy individual with smallpox material taken from the pustules of an infected individual. So, some were developing the disease, all developed other infection. So, administration of cowpox material to 8 years old healthy donor after 6 weeks inoculation from a smallpox pustule. No disease, large number of people results. Immunization schedule, evaluation of the effect and coverage. Okay. Now there are also categories like who should not receive the vaccination, like expectant mothers, like pregnant women, people with eczema or atopic dermatitis or an autoimmune disorder, people being treated for cancer, people who are HIV positive, people who have an organ transplant. So people who have been directly exposed to the smallpox virus should get the vaccine regardless of their health status. Okay, it is believed you need. Yeah. So Edward Jenner noticed that milkmaids were protected from smallpox if they had first been infected with the cowpox. Now, inoculation with cowpox, a bovine analog of smallpox, could confer immunity to smallpox, and thus the concept of vaccination was initiated. Incidentally, the Latin word for cow is vacca. Okay, so developed the concept of vaccination by immunizing an 8-year-old boy against smallpox using cowpox fluid. He then later injected smallpox virus repeatedly into the boy proving that he was indeed immune. He demonstrated that the protective corpus pus could be effectively inoculated from person to person and not just directly from Cattell reported finding on 23 subjects. He is known as the father of immunology and is a member of the Royal Society in the field of zoology. He was among the first modern scholars to describe the brood parasitism of the cuckoo, the area to perform this task. Then we have Paul Ehrlich. I think I've talked about this gentleman in one of the previous classes. He's basically the foundation of hematology, differentiated different types of blood cells by developing staining protocols. Okay, here the side chain hypothesis like recognize that a specific antigen elicited the production of a specific antibody, and he also hypothesized that these antibodies were specialized molecular structures with specific receptor sites that fit each pathogen like a lock and key. Right? He got the Nobel Prize in Physiology and Medicine with Meshkinov. Meshkinov basically developed the cellular theory of vaccination. His field was zoology again, and he studied phagocytosis in single cell organisms such as starfish larvae. So Mechnikov postulated that vertebrates could operate in a similar manner to remove pathogens than cellular phagocytic theory of immunity. Okay, he's called the father of natural immunity. Okay, and he also got the Nobel Prize along with Paul Ehrlich. Give me a minute. Okay. So when our bodies encounter pathogens, we discussed this previously, but just a background, our white blood cells will create antibodies against the pathogens, and this makes them easier for the immune system to destroy, right? So after the first infection, the body remembers how to make the right antibodies and can make them quickly if the same pathogen is encountered again. So people usually get chickenpox just once because they become immune to the chickenpox virus. Now the immune system remembers how to make the right antibodies and the pathogen is killed more quickly. The same pathogen tries to infect the person again. A pathogen like chickenpox virus enters the body and the white blood cells of the immune system create antibodies which destroy the pathogens. And the person is now immune to the pathogen and is unlikely to get the same illness again. The pathogen secretes antigens which make the person feel ill. For example, a pathogen like chickenpox can enter the body. The second will be the pathogen secretes antigens which make the person feel ill. And the third stage will be the white blood cells of the immune system. They create antibodies which destroy the pathogens. Right? And then the fourth step, which is the same pathogens, tries to infect the person again. Fifth is the immune system remembers how to make the right antibodies and the pathogen is killed more quickly. Sixth, the person is now immune to the pathogen and is unlikely to get the same illness again. So the child has a disease called smallpox, a virus that causes painful fluid-filled blisters to appear all over the body. Now, 30 to 35% of people infected with smallpox die. Now, in the 18th century, Europe smallpox killed around 400,000 people every year. Survivors were often horribly scarred and, in a small number of cases, blinded by the disease. So, Jenner had created the first vaccine against the disease by 1979. Smallpox had been completely eradicated due to a successful global vaccination program. So, what is a vaccine? Vaccines we have discussed in one of the previous classes. Vaccines create immunity without making you sick. So, vaccines contain either dead pathogens or live but weakened pathogens or parts of the pathogen. The white blood cells respond to the vaccine as if it were a disease by creating the antibodies. So, vaccines create active immunity, like the body creates its own antibodies. If a person is already sick, they can be given an injection of antibodies to help them fight the disease. This is called passive immunity. The protection is quick but does not last long. And then passive immunity can also occur when mothers transfer antibodies to babies across the placenta and in breast milk colostrum. Now, since 1991, children have been given 2 doses of the MMR vaccine to give them the most effective protection against measles, mumps, and rubella. Okay, so all drugs, including vaccines, can have side effects. So we have to balance the risk of taking the vaccine against the risk of catching a disease. So scientists test new vaccines on animals to make sure that they are safe for humans. Side effects, if any, are rare and usually minor, but like any drug, there is the risk of severe allergic reactions. So, drugs are tested in test tubes and using computers to try to assess if they may be dangerous to humans. Then, drugs are tested in 2 animal species to check that they are not toxic and to find the best dosage. Then, drugs are tested on a few healthy young men to ensure they are safe and to check for side effects. Then, drugs are tested on patients to check that the drug works to treat the disease in people. Then drugs are tested on large number of patients. Half are given the new drug, half receive a placebo. Now drugs receive a license so doctors can prescribe them to patients. So what did Edward Jenner use to develop the first successful vaccination? It will be the cowpox virus. Okay. I'll again stop here and wait for a few minutes. If you have any doubts, you can ask me or we can move on to the next question after 5 minutes. Okay, so the correct answer here is smallpox. So we'll move on to the next question for today, which is what was the main difference between the cellular and the humoral theories of immunity? Option A. Cellular theory emphasizes immune cells while humoral theory focuses on soluble factors in the blood. Option B. Cellular theory highlighted antibodies while humoral theory focused on phagocytosis. Option C. Cellular theory concentrates on complement proteins while humoral theory does not. Option D. Cellular theory is applied to bacterial diseases while humoral theory is applied only to viral infections. And option E. Cellular theory ignored the role of macrophages while humoral theory emphasized their importance. You have to tell me in detail. You can take a few minutes and then let me know if you can answer. Anybody? Anybody would like to answer? Okay, so the correct answer will be the first option. Cellular theory emphasizes immune cells, while humoral theory focuses on the soluble factors in the blood. So, the main difference between cellular and humoral theories of immunity is that, okay, the cellular theory was proposed by Elie Meshnikov. The core idea was that immunity is mediated by cells, especially phagocytes like macrophages, neutrophils. And these cells recognize, engulf, and destroy the pathogens. The key concept was that phagocytosis is the central mechanism of immunity, whereas the humoral theory, which is humoral theory of immunity, which is proposed by Paul Ehrlich. The core idea was that immunity is mediated by soluble substances in the body fluid such as antibodies, antitoxins, and complement proteins. The key concept is that circulating factors in serum neutralize or destroy the pathogens. Okay, so why option A is correct? It's because cellular theory is basically immune cells as written over here, and humoral theory is basically soluble factors in the blood. So this statement exactly captures the fundamental distinction between the two theories. Now option B is not correct because cellular theory does not emphasize antibodies. Humoral theory does not focus on phagocytosis. Option C is also not correct because complement proteins are part of the humoral immunity, not cellular theory. Option D is not correct because both theories apply to bacterial and other infections. And option E is not correct because cellular theory strongly emphasizes macrophages, okay, not ignores them. So we have talked about the study of immunology, like Pasteur was the first to successfully apply. Now, as we said, the principal function of the pathogenic of the immune system is that basically to protect the human body. Basically, it's a warrior system, basically protecting the human body from pathogenic organisms. Like pathogenic microorganisms can be in the form of bacteria, viruses, any form of foreign particle can be taken as a pathogenic organism, right? So, infection is basically the ability of pathogen to enter the host, multiply, and simulate an immune response. Stimulate an immune response. The disease will be a classical clinical manifestations of this of associated with the infection, right? Let's 1 second. Yes. So, innate immunity, as we discussed in one of the previous classes, made up of four forms: anatomical, physiological, phagocytic, and inflammatory. Anatomical can be skin, epidermis, flow of mucus prevents bacterial entry by washing them away. Normal flora can colonize epithelial cells of the mucosal surfaces. Pathogens can compete with them for attachment size. The physiological barriers can be pH, which is stomach specific, temperature, fever, soluble factors, and all, interferon, lysozymes. Phagocytic barriers like specialized cells perform most of phagocytosis, the macrophages, neutrophils, etc. Now, the inflammatory barriers like vasodilation, capillary permeability, leukocyte infiltration like chemotactic means increased adherence, leaky capillaries. Now, what are the chemical mediators of inflammation? C-reactive protein in liver, histamine, kinins, small peptides normally inactive in blood, example, bradykinin. Then macrophages can secrete cytokinins that affect the type of adaptive immunity. Macrophages and disease or dendritic cells present antigen. Okay. We'll not talk about these. We have talked about these things in one of the previous classes. Just we'll talk a little bit about cell media. Yes, so antibody mediated humoral immunity basically means directed against extracellular microorganisms and toxins. Like we have the B lymphocytes or the B cells which will differentiate into plasma cells which produce antibodies, function as antigen presenting cells or APCs. The classification of antibodies or immunoglobulins can be immunoglobulin M, immunoglobulin G, immunoglobulin A, immunoglobulin B, immunoglobulin E. Whereas the cell-mediated immunity is basically directed against intercellular microorganisms. Non-phagocytic cells and phagocytic cells, T lymphocytes like differentiate into effector cells following antigen presentation by antigen presenting cells. The functional types of T cells can be helper, CD4 T cells, Th1, Th2 cells, cytotoxic, CD8 T cells, regulatory like CD4 and CD8 T regulate. Okay, so that is basically the difference between humoral and cell mediated immunity. We will not go into these details, we have already talked. Yes. So, cell-mediated immune responses involve the destruction of infected cells by cytotoxic T cells or the destruction of intercellular pathogens by macrophages. The activation of naive T cells in response to antigen and their subsequent proliferation and differentiation constitutes a primary immune response. Now, cellular immunity protects the body through T cell mediated immunity or T cell immunity, like activating antigen specific cytotoxic T cells that are able to induce apoptosis in the body cells, displaying epitopes of foreign antigen on their surface, such as virus infected cells with intercellular bacteria and cancer cells displaying tumor antigens. Again, we'll not go into too much detail. So, humoral immunity is basically the aspect of immunity that is mediated by macromolecules found in extracellular fluids such as secreted antibodies, complement proteins, and certain antimicrobial peptides. Humoral immunity is so named because it involves substances found in the humors or body fluids. It contrasts with cell-mediated immunity. Its aspect involving antibodies are often called antibody-mediated immunity. Now, humoral immunity refers to antibody production and the accessory processes that accompany it, including Th2 activation and cytokine production, germinal cell formation and isotype switching, and affinity maturation and memory cell generation. So, it also refers to the effector functions of antibodies, which include pathogen and toxin neutralization, classical complement activation, and opsonin promotion of phagocytosis and pathogen elimination. Now, B cell activation is a large part of the humoral immune response. So, B cell is triggered by when it encounters its matching antigen. The B cell engulfs the antigen and digests it. Then it displays antigen fragments bound to its unique MHC molecules. This combination of antigen and MHC attracts the help of a mature matching T cell. Now, cytokines secreted by the T cell help the B cell to multiply and mature into antibody producing plasma cells. It is released into the blood. Antibodies lock onto matching antigens, and the antigen antibody complexes are then cleared by the complement cascade or by the liver and the spleen. Now, the concept of humoral immunity developed based on analysis of antibacterial activity of the serum components. Hans Wagner is credited with the development of the humoral theory. So, in 1890, basically he described alexins or protective substances which exist in the blood serum and other bodily fluid and are capable of killing microorganisms. Right? So alexins later redefined as complement by Paul Ehrlich were shown to be the soluble components of the innate response that lead to combination of cellular humoral immunity and bridge the features of innate and acquired immunity. Okay, we will not go into too much detail. We have So coming back to the question that we started with today, the answer will be cellular theory emphasizes immune cells while humoral theory focuses on cerebral factors in the blood. Okay. Okay. So if anybody has any question, doubt in this question, you can ask me now. So good. This was the last question for today. If you have any questions, you can ask me now, or if you, I'll upload all the slides and the video also. Then we can discuss uh, in the next class. So if you have any doubts, you can ask me in the next class also once you have gone through all the slides. So I'd stop the session for today. We'll meet again next Monday, same time. Thank you.